When we look at a case like this, the chief complaint of the patient was that the teeth are forward placed and there is gap in my teeth. At rest, if you see, the lips are parted away considerably. There is diastema at the anteriors. But at this point, I'm only going to concentrate my energy on the face. I would see the symmetry of it. Minor asymmetry, which is absolutely normal within normal range. I see that the patient's chin is fairly bulky. Okay, there are no major concerns for me when I look at the patient's face. When I look at the profile, I see that the nasolabial angle is acute. The forehead is straight and the nose is normal. It is not a big nose. It is not a nose that is angulated in the upward direction. Okay, so I'm really happy with the nose. I'm happy with the forehead. What I am not happy is the nasolabial angle. Okay, so I would want the nasolabial angle to reduce. That means if I can take the upper teeth behind, reduce the support of the upper lip, I would definitely do that. Right, similarly the lower lip is falling ahead. The lower lip is falling ahead, so I need to improve the lower facial height as well, so that there is proper support for the lower lip and the lower lip also gets substantially retruded. Right, I'm not so happy with the chin of the patient, but when I look at the patient's profile, it is not something that I would be worried about. Right, so this is how I analyze the profile of the patient. When the patient is smiling, the amount of incisor that is seen is also very important. Look at the nasolabial angle, it folds considerably. So I would really want to reduce the support of the upper lip. So when I look at the patient's dentition, I'm going to look at things to do so that I can reduce the support of the upper lip. Now I see intraorally. I see a huge midline diastema. I see spaces distal to the lateral. I also understand that the teeth are proclined. Okay. When I analyze the palate, I see that the palate is slightly V-shaped. It's narrow. It's a V-shaped arch. Okay, what I see is crowding in the lower anteriors. These are the things that I'm seeing here. I'm really happy with the molar relationship bilaterally. Really happy with the molar relationship. The canine relation here is very, very good. Not so much on the other side. So now these are the points that I analyze for myself, right? And also there is a deep bite. The lower anteriors are, I think, almost touching the papilla here. So what are my treatment objectives? What are my treatment objectives? My treatment objectives would be to first correct the angulation, utilize these spaces, take the teeth behind, that is when the angulation is corrected, and widen the arch a little bit. I would like to see a more U-shaped arch, right? Then I would also want to relieve the crowding of the lower dentition, lower anterior dentition. Now these are all my treatment objectives. One, I know what the problem is. Similarly, I need to understand what my treatment objectives are going to be. How I'm going to achieve the objective is a different story. That is my mechanotherapy. But I need to understand my goals for a particular case. If I don't have understanding of what I need to achieve, I will not be able to plan my mechanotherapy accordingly, and I will never be able to deliver the result. Okay, so enlist your diagnosis, understand your database, enlist the objectives you want to achieve, and then start planning your mechanotherapy, and then comes the starting of your case. You do not start your case and then plan all of these things. You first have to go through all of this, understand the data, have a treatment plan in hand, and then you start the case. Fabricating a treatment plan, changing your treatment plan during the course of your treatment is not very good. Okay, so these are my objectives for this case.